Good morning, everyone. I thank the scientific committee for this opportunity. I am going to talk on the macular evaluation in all stages of glaucoma from the early to severe. Traditionally, all the glaucoma patients are evaluated by evaluating the optic nerve head and circumpapillary retinal nerve fiber layer. And in the perimetry side, it is always 24-2 or 30-2 begin with. But currently, we are seeing that the glaucoma can affect the macula in the very early stage. I don't have any financial disclosure to make. So, why should we study macula in glaucoma? We know that the main pathology in glaucoma is the retinal ganglion cell death. The retinal ganglion cells are dying, which is reflected in the loss of the retinal nerve fiber layer and itself the cupping of the optic nerve disc. And majority of the entire ganglion cell population reside in macula, which is plus minus 8 degrees from the center of the fovea. So, though the macula area is only 2% of the total retina by area, it contains about 50% of retinal ganglion cell of the entire retina. This signifies its importance, and we have to think about the quality of life of the patients. Most of the quality of the life of the patients decline in glaucoma because the damage to the macula. The patient is not bothered about his nasal strip or paracentral scotoma. What he is bothered is about loss in central vision, like loss in contrast sensitivity, loss chances of fall, difficulty in driving, difficulty in reading. All those are functions of central vision. So we should be careful about evaluating the central vision function in case of glaucoma. So another importance of macula is that the RGC body itself is 10 to 20 times larger compared to the nerve fiber layer, which are the axons, and it is at macula it is multi-layered. So it is thicker at the macula, and any change is easily detectable at the macular level. And variation in the ganglion cell is very small at the macula, and it is another important point is that it is less affected by the factors like size and tilt of the optic disc, parapapillary atrophy, which always affect the retinal nerve fiber layer. So why is macula often overlooked in previous years? Because of certain misconceptions. We were traditionally using the 24-2 field test, which were only having 10 points in the central 10 degree. It was the central vision was not well demarcated and well differentiated in case of perimetry. So we were missing the early changes. And in macula, we believe that the central vision is preserved till late, so it is not available not affected in the early stage. Actually, that is a misnomer, because at the center it is 6 to 7 layers thick. Till the last layer of the ganglion cell is gone, the field defect will not come on the perimetry. So we used to think that it does not affected in the early stage, but it usually simultaneously or earlier than peripheral vision, macula, central vision gets affected, which we can know by the 10-2. And due to the advent of the newer swept source and SDOCT, we can now segment the proper segmentation of the macular layer, and we can know that changes also occur in the macular area in glaucoma. So if we do only 24-2, we can miss certain 10-2, certain field defect, which is well delineated in the 10-2. So it should be done if we suspect something is happening at the center. That I am coming later on. And the macular anatomy, few knowledge about the macular anatomy is important. The axons of the retinal ganglion cell, which from both above and below the horizontal raphe arch above the macula, and they come to the superior and inferior part of the disc, which are usually vulnerable to glaucoma defects. And here you can see that the superior fibers, they end in the temporal area, whereas the inferior zone, they are entering in the inferior macular zone, inferior zone of the retinal disc, which is at the most vulnerable. So inferior fibers are more at risk. And here the Donald Hood concepted a model, and here it is told that the less vulnerable area inside the macula, it comes to the temporal region, which is least affected due to the papillomacular bundle, and the more vulnerable area, it is coming to the inferior retinal area, and it lies between the 295 and 322 degree on the inferior part of the disc. And damage to the fibers passing through the superior vulnerable zone and inferior vulnerable zone, which is not in the macular vulnerable zone, that causes nasal steps, arcuate scotoma in peripheral field, and whereas the fiber coming from the macular vulnerable zone causes paracentral defect. And moreover, progression in case of glaucoma is also we can judge better in case if we do the ganglion cell analysis, because after the thickness reaches the 40 micron level, there comes the floor effect in case of retinal nerve fiber layer, and further decrease in the field we cannot check by this retinal nerve fiber layer analysis, where glaucoma ganglion cell analysis is working till a later stage. So in case of advanced glaucoma, to know the progression also, it is very helpful. And macular OCT measurements have a high reproducibility in the advanced stage also, they do not vary much. So for this reason, in the diagnosing and progression in case of advanced glaucoma, macula fielding, the ganglion cell analysis is very much important. So in certain special situation also, the macular ganglion cell analysis is very important. Morphological changes in the optic nerve like tilted disc, stretching of the circumpapillary retinal nerve fiber layer, and peripapillary atrophy can cause OCT artifacts if we do only RNFL thickness. But in the ganglion cell layer is less affected by those things. And in myopia, there is stretching of the retinal nerve fiber layer, and there is temporal displacement of the retinal nerve fiber layer peak, which will cause artificial thinning of that area, and that will cause the red disease, which can be avoided if we do the retinal ganglion cell, particularly in myopic patients. And optic disc hemorrhage is always associated with more macular involvement. And normotension glaucoma, paracentral defects are more common. So in those patients also, it is very helpful to examine the macula by the ganglion cell analysis. And here are the few examples in which you can see that there is red disease occurring because there is temporal shift of the retinal temporal shift of the peaks, and it is due to the stretching, it is very thinned out and causing the red disease. And in early NTG also, even if you see one spot in the 20/2, we should think that the center vision is threatened, and we have to order a ganglion cell analysis in those patients. And there are certain limitations with if we do only ganglion cell analysis, because various optic neuropathy, including compressive and ischemic neuropathy, can cause defect in the macula. But if we see carefully, there is a temporal Raphe sign, which is very specific for glaucoma. But in case of other neuropathies, they will have this type of ganglion cell defect, and if we see carefully, then the temporal Raphe sign will give us some help. That it is a glaucomatous defect. So to conclude, the macular evaluation is very important for early diagnosis and monitoring glaucoma progression, particularly in advanced cases due to the floor effect if we do only the RNFL, and it cannot show more for progression. And it is particularly helpful in certain, including certain important conditions like myopia, which is very common coexistent with the glaucoma. And early glaucoma patients with macular damage should be treated more aggressively to present visual disability, because our glaucoma patient need their central vision very much. A slight amount of difficulty in the reading or driving will cause degradation of their quality of life. So we should be carefully evaluating the macula. And next question comes whether we should evaluate macula in all the patients. Should we do the 10-2 in all the patients or 24-2 to start with? If we see any single point of, with having a black square in the 20/2, that is indicate that that area is going to affect, and we have to order a 10-2 simultaneously. If we saw any defect in the inferior vulnerable zone, inferior arcuate area, then that is also should indicate us that macular area is going to be involved, and we have to treat aggressively. So if you keep these things in our mind, then central vision of our elderly patients will not be affected, and quality of our life of the patients will be maintained. Thank you for that.
Madam, where you will advise this macular OCT for the glaucoma? Is it for early stage or advanced stage?
In early stages also, the macula is being involved, though we are not seeing it or recording it due to the either the segmentation error or this proper segmentation, and we usually do 24-2. But if we are suspecting that central area is going to be involved, like if the patient complains of, we send the patient for visual recording, he will have 6/6 vision, but he will have difficulty in contrast sensitivity, he will have difficulty in driving, he will be going on telling us that these things, we will record the visual 6/6 and we'll tell them nothing is happening, you go away, it is due to cataract, but it may be due to macula. In such patients, we have to order that macula evaluation. And another thing, one square spot in the centermost 4 points. If it is involved, then that much of ganglion cell is lost, because at the center, ganglion cell is 6 to 7 layers thick. So if for one black spot to appear, normally 130 to 140 ganglion cell have to be lost for that one particular spot. So in that case also, we have to order another 10-2. It may be difficult for the patient in the same setting. Either we can give a gap of 30 minutes, or in the next visit we see the central vision, but that is very important, because that is what is bothering to the elderly group of patients.
24-2.
24-2 is routine.
10-2.
10-2.
But in between there is 24-2C is also available.
That is coming,
nowadays.
but nowadays recent reports are not very much encouraging about that, though they see certain points. And in that also, if the 24-2 see that they are adding 10 more specific points in that area, which are more prone for glaucomatous damage. If we see any defect in that, then again we have to do the 10-2, because 10-2 elaborately examines those areas.
Great, madam. Please stay on in the dais.
Okay.